Good afternoon, colleagues. Welcome to our eco session. Thank you so much for joining us. And thank you for your patience. We usually are supposed to start at 1 p.m., but because we're still waiting for other colleagues to join us, so I think that they're going to join us as we continue with the session. So my name is Nancy Chabamo. I will be facilitating today's session. With me, I'd like to ask them to introduce themselves.
Good afternoon. Sunday.
My name is Sandy Mantan from Eswatini hospice. I'm working as a research and training officer here and the program coordinator. Thank you. I'm with Mrs. Sibongi here. Maybe she can talk.
Afternoon, colleagues. I was disturbed. I'm sorry, I was disturbed by there was a little bit of sound, but I'm here with Mrs. Sibongi. Thank you so much.
Thank you, Muguni. Can we kindly introduce ourselves, maybe starting from Cyprian? Please introduce yourself and let us know if you are joining with anyone from your side.
I'm calling you to Hello, group. My name is Cyprian Matsonja from the NCCU department. I work as the palliative care officer and the navigator.
Thank you, Cyprian. Are you joining with anyone?
Sorry?
Are you joining with anyone or are you by yourself?
I'm with Kelly. I think she's going to greet you.
Oh, okay. Can we kindly move to Zamo Buhle? Please introduce yourself.
Good afternoon, team. My name is Zamohu Lukele from the National Cancer Control Unit.
Thank you, Zamo Buhle, for joining us. Can we move to Nomathemba? Please kindly introduce yourself.
Nomathemba, can you introduce yourself by muting your microphone and then talk?
Hello, everyone. Hello. Hello.
Hello.
Yeah. Yes, thank you, Zama. I'm Nomathemba Kilinza from the Sexual Reproductive Health Unit in Manzini region. Thank you.
Thank you, Nomathemba, for joining us. Are you joining by yourself or do you have any other colleagues?
Yeah, I'm by myself.
Okay, thank you. Can we move to Pennington?
Hello, everyone. My name is Pennington Dlamini from Eswatini Hospice at Home.
Thank you, Pennington, for joining us. Can we move to Malaika? Malaika, please introduce yourself. Okay. Can we move to Eric? I hope I'm pronouncing your name okay, and apologies for maybe how it sounded. Please introduce yourself.
Hello, everyone. Can you hear me?
Yes,
If
yes.
we can hear.
Okay, my name is Rakev. I'm a nurse working in a clinic group.
Thank you for joining us, Raquel. I think we have, okay, can we move to Mage Zodwa? Please introduce yourself, Mage.
Hello, team. My name is Joshua Kameta, working for Eswatini Hospice at Home. Thank you.
For joining us, Mage. I think we have all introduced ourselves, but we can also do, as other colleagues have already started, introducing themselves in the chat box. Maybe we can continue with our introductions there for those who haven't. So for our last session, we were looking at risk mitigation strategies for opioid prescribing. We were taken through by Mr. Pius Pumayo, who touched on really important points there. And if you missed out on that session, you can go to our YouTube channel and be able to catch up on that session. And for today's session, we are going to be looking at treatment strategies for opioid use disorder, and Mr. Sandile Matam will be taking us through. But before we get into our presentation, can we remember to maybe avoid background noises by silencing our gadgets and remaining muted unless we want to communicate anything. And if we want to communicate anything, we can use the raise of hand, or we can unmute or use the chat box to say anything that we want to share, maybe with the entire team. So at this time, I will hand over to Mr. Mashamo to give us his presentation on treatment strategies for opioid use disorder.
Thank you so much, Mercy. Thank you so much, team, for joining us today. And thank you so much for those who have joined us for the first time. It's never too late, so you will catch up from where we are now today. So in the past sessions, we have covered a lot, but we are hoping even today we will cover more. So we are hoping to cover a lot today. So we have been looking at this theme, which is a series for some time now. We started around October last year, and now we are here. We are in the middle of the foundation or the roofing of the houses. We are going up. So we are hoping we will be able to catch up with everything, but we will take you into picture. In the last 3 sessions, we were looking at chronic pain management strategies, especially for people with serious illnesses, which we call life-limiting and threatening conditions. So today we will be looking at the treatment strategies for opioid use disorder. In our last session, we were looking at mitigation strategies in case to avoid opioid use disorders when we are using the opioids. So it has been a journey. So after completing this presentation today, we will be able to identify, manage opioid use disorder in patients with serious illnesses, and we will be able to define approaches for treating pain in people with opioid use disorder, and list these considerations and steps for temporary or deprescribing. So we'll be just looking around this one to complete the series. Actually, to bring to you on the summary of what has happened in the past, we started when we were doing this, the past 3 sessions, we looked at the non-opioid chronic pain management when we say that it is very critical that before you think of prescribing any opioid or any drug, start on looking on the non-opioid part or the non-pharmacological and non-opioid mechanisms or interventions. It should include your pharmacologicals when we're using our national palliative care guidelines, we will refer to that one as the step 1 drugs, including your non-pharmacological interventions. So we covered that one. And then the second session, we looked at how to prescribe an opioid for chronic pain. In the previous sessions, we looked at the principles of prescribing an opioid, but this time we're looking concerning chronic pain, which is one of the types of pain we are facing in palliative care, and a very big challenging one. So in the last session, we were looking at risk mitigation strategies. So now we are about to look at the treatment strategies for opioid use disorder. So when we started this, we said that the pillar to go to quality of life, which would be the increased quality of life and decreased risk for all patients, that would be our major goal to manage chronic pain, because we want to attain that one. So that's what we want to achieve actually when we are doing this. Once we have reached that area, then we will know that then we have done a great job in terms of managing chronic pain, which will be the improved quality of life of these patients and the decrease of quality of life. So that will be described by the improved quality of life, and then the risk of the opioids will be decreased for all patients. So then we unpacked certain principles when we were doing this. One of the principles that we looked at was assessment. So we said that when you are doing your pain and functional assessment, you need to do it comprehensively, and we have covered it in certain areas and how best we can do a comprehensive pain assessment. It is there in our platform. We also looked at the issue of when we are dealing with chronic pain, as we know it's a brain disease, we need to build a relationship with the patient so that they trust us and we trust them and we know them better. So we need to build a relationship continuously. So good communication and trust building are two pillars in palliative care. Without good communication and building trust with our patients, we will not be able to manage their pain very well. And when we are doing your pain assessment, we also mentioned that don't ignore the functional assessment of the person. Normally we use scales like the ECOG, the GIOF scale, many different tools that can be used to manage or to assess the functionality of the patient. We also talked about the use of non-opioid therapies. Always, please consider the use of non-opioid therapies first before considering any opioid prescription. And then also we talk about then when we are prescribing the opioids, we said that we need to follow the standard practice and the universal precautions. So we need to adhere to that one, and also our guidelines in the country show that, and WHO and CDC, they provide information on those issues. But then universal precautions, including the standard practice, which we covered in our previous month's sessions. We're looking around those standard practices on how we go around prescribing in opioid. But today, then we will also look around the prescribing in our presentation. So I'm just introducing what has happened and where we are going, because this is one last part under chronic pain. In the last session, we'll be getting our tutorials from Uganda professors. So we'll be looking around other issues. Maybe to remind us is that we need to understand every time. I will re-emphasize the issue that we redefine what is a serious illness, which we say is any serious condition or any health condition that carries a high risk of mortality and decreases the quality of life and function of the patient. And there's an excessive strain on the caregivers, and that one is diagnosed or is categorized under serious illnesses. And then another one is chronic pain. Chronic pain is a brain disease. Our previous presentations, they alluded more in terms of how it becomes brain disease. And then frequently limits life and work. You know, when you have chronic pain, you become non-productive and your life, quality of life goes down. And it has an impact on functional impairment. And also it has impact of depression and anxiety. And it may result to substance use, and it decreases the quality of life. So it's a very serious issue that you have to deal with when we talk of chronic pain. And also we say that we need to define also what is an opioid use disorder, which is a brain disease and is not under the control of the patient. Once the patient is diagnosed with it, it becomes impulsive, he cannot even control himself. And we need to remember that this one is a problematic pattern of opioid use and causes significant impairment or stress. And the diagnosis is based on a specific criteria, which we'll look at today, on how you can say then this is how a person is diagnosed with opioid use disorder. Psychologist Sugati in our previous presentation presented on this criterion when we deal with opioid use disorder and how we can say a person is now diagnosed with an opioid use disorder. And then also we have opioid misuse, which we need also to understand, which is taking an opioid more than what is prescribed for. We say it's a red flag and abnormal behaviors, and you sometimes find that there are issues that has to relate to the one. And then also we need to understand that under chronic pain management is what we call deprescribing. So as clinicians, this one is a clinician supervised process of discontinuing medication. We need to know that taking opioid, make an example, is not a lifetime treatment. So at some point, we need to discontinue it or prescribe or taper it down. And this type of medication at this point, we are prescribing or stopping medication that is no longer beneficial to the patient or where risk is more than actually the benefit. So the arrow has to look the other way around. So the risk is more than the benefit. So then we have to stop those drugs because they are not beneficial to the patient. I'm just bringing this to you. So when we are diagnosing an opioid use disorder, we won't dwell this much because Sugat explained a lot from this, but we use the DSM-5 to diagnose an opioid use disorder. So we need to understand that one, that we are using it, and it has these points that in it that are stated, and the criteria will include these issues. A great deal of time is spent on activity necessary to obtain or use or recover from it, craving or strong desire to age or use. But what I'm so interested about this DSM-5 issue is that there's a special consideration when it comes to tolerance and withdrawal, which is these 11 bulletins, they fall under the DSM-5 criteria. So the patient who will be diagnosed with an opioid use disorder must meet 2 or more of these criteria in a period of 12 months. So you must meet, the patient must meet any 2 of them. But then the criteria for opioid use disorder manifests different in patients prescribed opioids for pain compared to people who obtain opioids from non-medical sources. So it manifests differently. So like tolerance and physical dependence, like it appears in the DSM-5, are normal in patients on long-term opioid therapy. So we expect them to sometimes experience those things and are not among the criteria for opioid misuse or opioid use disorder in the DSM for these patients. So we need to know how do we look closer to patients who are taking the treatment for a long time, because those ones are under prescription. But then the issue of loss of control and use, despite consequences, remain an important feature of an opioid use disorder diagnosis. So once the patient is continuing taking it, even if it is the risks that are so high or the consequences are too much negative, then we need to consider a patient to have developed an opioid use disorder. So the critical issue is, you cannot just say, this patient of mine is abusing the patient, or I'm seeing just 1 or 2 things that are appearing on the DSM-5, then I can quickly rush and say, I must stop this and stop the patient to take the opioids. You need to sit down and dig deeper to find out what exactly is happening with this patient. And then another issue that we need to know is that the risk that are there for opioid use disorder. It's just that we need to know that there are certain factors that correlate with opioid use disorder. I've repeated many times and it appeared many times in our presentation. One of it is that the past medical history. If the patient has a past medical history of opioid use disorder, then the patient is a high risk. Current or past history of non-opioid use or substance use disorder like alcohol, any drugs, heroin, or whatever drugs the patient has been using before, that past medical history, including family, we need to look closer to that patient because that patient is a high risk to develop or to move towards opioid use disorder. A patient with anxiety, a patient with a history of trauma, patients who have certain mental health diagnoses like mood disorders and others, patients who are taking any psychiatric medications, those patients are high risk to develop opioid use disorder. So we need to look closer. So if one or more of these factors is present, the patient should be considered higher than standard risk for opioid use disorder. Then that means the universal precautions need to be more close and strict for this patient. For then, what do we do if our patient is a standard risk, like the patient that we normally see every day, who doesn't have any of the risk above? How do we then deal with those patients? These are the things we can do. One is to choose a pain management plan and set smart goals for the patient, for the opioid therapy. So you need to choose the plan and how you are going to do or how are you going to deal with the opioid therapy. How is the patient going to take it? Discuss with the patient. In our previous presentation, we talked about the importance of goals of care discussion. This is where we have to sit down with the patient and say, you know, you are a high-risk patient for this, and then this is the plan we need to sit together and agree on and see how best we can help you so that you cannot become an opioid use patient or you cannot develop an opioid use disorder. Another thing is that other facilities may opt to use informed consent forms where patients will sign. The oncology people will know better this one when they are enrolling patients to chemo. And also, what we need to do that is to screen for multiple prescribers using the state database. When we are still, as a country, growing towards this CMIS system, you know, I'm happy today we have a rep here who is working for the clinic group. So you'll find that we have a client in the public sector or from the private facilities who will be scared to go back to refill from the private facility for an opioid, and then will go to a public hospital to do the same refill. So we are unable to trace. So as a country, we still need to move forward to centralize and be able to control and be tracing our patients. So every person needs to have this database so we can able to trace them to see if they begin to consult different or multiple prescribings for the morphine. Otherwise, it is good and recommended for a patient to go and refill opioids from one prescriber or one facility so that the patient can be well managed. If ever there will be a referral to another, then let these two facilities communicate and be aware. And this one leads us to the issue of we need to document properly. Initially, when we started this plan, Mr. Villa presented about it. It's here in our platform on how best we can document a prescription for an opioid. That will help us understand what is happening. And then also we need to assess for e-diversion, and that is also educate patients and pill counts. You know, patients will misuse the medication, and some relatives will steal the medications for these patients. So we need to be able to follow up the medication like we are doing with ART treatment. Also for opioid, we need to be speaking that way, that we know that if you are taking this much, we expect you to come with this much for refill. So we know exactly what is happening with this medication because they can easily be abused. And also another thing is that we use frequent and regular follow-up for these patients who are standard. So that's why sometimes in facilities, you will find that patient initiated on morphine or taking morphine, They will be followed for 30 days or 2 weeks, depending on the risk level. They will be followed monthly, so that we know how are they coping. And they will be linked sometimes with institutions like us, Hospice at Home, and other institutions for follow-up, so that we can know how they are coping. And then also what we need to do is to monitor the opioid misuse behaviors and assess for risk of developing opioid use disorder at initiation and every visit thereafter. It means the continuous assessment of the pain and the functionality of the patient is very critical. And the continued communication and building of relationship will help you to differentiate between opioid use disorder and opioid misuse, because opioid misuse may be a source of different issues that you need to eliminate before you can diagnose it that way. And then also assess and document efficacy at every visit. We need to know, is my prescription for this patient effective and working for the patient? So I need to ascertain those issues. Complete an opioid treatment agreement, sometimes they will do that. Different facilities will opt different way. With other facilities, we will also at regular intervals or irregular intervals, or when required, prescribe a urine drug test to ascertain if the patient is also taking other substances that could contribute to opioid use disorder. So they will also do that. So Dr. Smekane explained that one very well. I cannot go deeper in it when we're looking at the standard practices of prescribing opioids. And then also we need to schedule more frequent follow-up visits and consider pain and palliative care consults. So that one is very important. And then for high-risk patients is the same standard plus this following one, which is prescribing opioid at least every week. Do some follow-ups because this one is a high-risk patient, and then you need to do a frequent visit. If there is a diagnosis of substance use disorder, support the substance use disorder treatment and recover. And normally these patients, you will find that they are already going to our national psychiatric hospital for management. So we cannot then stop them from taking the opioids, because we remember that we are giving them this opioid for treatment of pain or for management of pain. So the best way is to support them, but then the best way also is to refer them for addiction specialist or to the psychiatric hospital for further management, because that's when they will be helped to escape from such a case or problem. So other than to stop them, then we need to find a way how to manage and then deal with the issue of substance use that way. Mitigation strategies, I won't dwell much here. What I will say, mitigation strategies to reduce opioid harm. The first thing we need to do, let's practice non-judgmental communication. Actually, when we're doing communication in our previous presentation, we say the backbone of palliative care is communication. We need to communicate. Conduct substance use assessment before, during opioid therapy. Every time, let's do the assessment. Let's use the universal precautions as we described in our previous session. Let's also understand that forcible tampering should not be used to mitigate opioid harm. Don't force it. It must be between the patient and the healthcare provider agreeing on how best they can do it. So I will not dwell much here. These are just communication tips on how best you can do or communicate with these people or this patient. Actually, these are just core communication tips. So we need to embrace them. Actually, I would say under this, let's practice communication skills. Every day, let's practice as clinicians. I know sometimes we are overwhelmed, but let's try by all means to communicate. Then the goals of treatment for substance use disorder or opioid use disorder, the goals are to reduce risk associated with problematic opioid use, and also to reduce related morbidity and mortality. Sometimes they are injecting themselves, they will die. So we don't want them to go there. And increase retention in treatment for substance use disorder, because we want them to be retained during their treatment so they cannot be lost for follow-ups. We want to improve general health functioning and well-being of these people. And other than all, we want to improve their quality of life. So I will not emphasize that much on this one. The purpose of the medication for this treatment then is to suppress opioid cravings. So when they are prescribing, the physician or the specialist will prescribe this medication, one, to suppress the cravings for opioids, and then re-establish the reward pathways in the brain, because remember, this is a brain disease. Control symptom of opioid withdrawal, so they are withdrawal there, so we have to control them. Then block the reinforcing effects of ongoing opioid use. We improve emotional and physical well-being. We promote patient engagement and recovery-oriented activities. So the best practice recommended by CDC and other studies is that we use both pharmacological and plus behavioral therapy in the treatment of opioid use disorder. So this drug they are using it, buprenorphine. It can be just buprenorphine alone or buprenorphine. Buprenorphine plus and naloxone. So it may come in fixed dose combination or not, but this is the best practice, which is pharmacological and behavioral. Then we also have behavioral interventions that we use. So when we're talking about this one, I've mentioned that by using both pharmacological and behavioral intervention, the patient benefits from the following, which is reduced stress and negative emotions, because they begin to develop negative emotions, and getting more pleasure from natural health and rewards, they begin to develop interest and pleasure from natural and healthy activities. So it increases the ability to avoid things that can trigger or return to substance use. So they are beginning to have adaptive practices or behaviors, and improve ability to regulate one's own behavior. That's why under this, we have what we call motivational interviews, whereby we help them to adapt when they're doing CBT. So we are helping them to adapt and come back to their normal life. I will not dwell much in this one, because in our guidelines, we have only naloxone, which also dealt with the toxicity when we are reversing the high doses of morphine that is causing damage. So we are using naloxone. But I would say that buprenorphine is a partial amino agonist. It's a life-saving treatment used to treat opioid use disorder. So this one is for, I would say, it's a treatment for addiction. It's safe and effective in reducing opioid use cravings and withdrawals. It's more like the other drugs, the full amino agonists like morphine and others, but this one is a partial. So it acts like the other one, but it displaces the full ones. So once physical and emotional symptoms have been mitigated by the buprenorphine, then the best practice is to add counseling and behavioral, because now the patient is stabilized, is okay. Otherwise, this drug is expensive. Sometimes even a private counseling is not covered in the medical effort. I don't know how we stand up with our facilities, how they go. Otherwise, naloxone is there, but it's for overdose or toxicity, but yet preference for opioid use disorder. So the advantages are here. I will not dwell that much, but it's good to titrate, less cravings, fewer toxicities, and lower risk of diversion, and it has a lower risk of leading to hyperalgesia. So it's very good. It's just that it's expensive drug. Okay, treating pain and opioid use disorder, how then do you go? First of all, this one requires pain specialists. If you are not sure, don't try, because you might push the patient deeper into the problem. And for pain and opioid misuse, a prescription of buprenorphine in divided doses is recommended. But then, we end up using what we have. But then, this one is the best. If ever the patient can afford such drugs, you may help them get them. Microdosing is preferred in serious illnesses, so you go slow and small. And then it's very important to follow the standard practice and universal precautions as we have discussed them in the previous presentations. And then we are talking about deep prescribing. Opioid temporary is especially important in the following situations, especially when an individuals who desire opioid taper, we do opioid tapering. You know, sometimes patients will say, please, nurse or doctor, kindly reduce the dose for me, it's too much. We do tapering for them, right? Individuals who are not achieving functional goals despite opioid therapy. If the patient, we are giving them the opioids, but they are not achieving functional therapy, then we will say we need to taper the drug because it's not giving us what we are looking for. So that's one of the classical indications of continuing with an opioid is when the opioid is giving the patient the best optimum level of functionality, then we are saying the opioid is working. Individuals with high risk of those experiencing opioid-related harms, I've listed many here. If any of these harms are there, we need to taper that opioid because it's gonna kill the patient. So that's what I can say there. Then the goals are here. The goal of tapering the patient is the patient well-being. And that is not an arbitrary reduction in the number of pills a patient takes. So opioid tapering should be voluntary and individualized, you know, and the goal of reaching the minimum effective dose of the opioid. So that's what we need to do. When we are tapering, we are trying to reach the minimum. We are not taking away the patient from the drugs. And tapering should be slow, not more than 10% per month, because then the patient will suffer the withdrawal symptoms. So you take care of the patient to avoid withdrawal symptoms and maximize an opioid pain treatments as we have discussed them before. Now we'll be looking at the principles of tapering. Whenever you will be deciding to taper a drug, the first thing is you go slow. The second one is you partner with the patient, the community, the mental health, the specialist, and everyone. We need to work together when we are tapering down. Let me make an example. If a patient in RFM, they are tapering the patient, and then the patient goes to Barbara, they increase the dose of the patient. So we are not working with the patient and the team very well. So we need to work together. Once the goal is tapering, let it be documented and let the tapering rate be stated and how far we are now, so that whenever the patient goes, we will be able to help the patient. Number 3, you support, and number 4, we encourage collaboration between the patient and the team. That's why we need an IDT or an MDT approach in management of this patient, like we are here today together. And then the tips are, you minimize the dose, you motivate change, and you support alternatives, and you allow time because it cannot happen instantly. And then you promote the patient's buy-in on the exercise, because without the patient buy-in, you will not be successful to taper the patient. And you acknowledge the progress we've made, even if it's as little as possible, acknowledge it. Before maybe I finish, I will say that these are my takeaways, is that patients with serious illness are not immune to opioid use disorder and opioid-related harms. Opioid use disorder is treatable chronic, relapsing and remitting pain disease that involves alteration in the pleasure reward system resulting in compulsive use of opioids. Using universal precaution, avoiding stigmatization, language, clear communication, help preserve trust. And this one will help you achieve the goal whereby quality of life and risk would be attained. Medication and treatment is the gold standard for management of opioid use disorder because it helps you reach that one very well. Pharmacological interventions is considered best practice for treating opioid use disorder whenever possible, should be used in combination with behavioral interventions. Patient-specific factors such as prognosis, motivation to change, affect opioid use disorder treatment options. So the prognosis of what is happening with the patient. Opioid tapering should be voluntary and individualized with the goal of reaching the minimum effective dose for that patient. And tapers should be slow as clinicians. We need to be slow, at least less than 10% per month. You go down, then taking care to avoid withdrawal symptoms and minimizing non-opioid pain treatments. I think that's what I can share with you, Tim. These are the references for further reading. You can access them, but we have also uploaded the same materials into our iEco platform. So This marks the end of the chronic 4 sessions that we're coming back to pay. Otherwise, we are still continuing with pay as our platform is showing. Thank you so much.
Thank you, Mr. Mashamo, for the presentation. I hope everyone was able to follow quite well what Mr. Mashamo was sharing on the strategies we can use to treat opioid use disorder. I don't know if we have any questions for him or any comments based on the presentation. Okay, there's a comment from Nomatem who says, thank you, Mashamo, for such an informative presentation. I don't know if we have any questions for him. Maybe we can use the raise of hand or unmute. Okay, there's a hand from Cyprian. Kindly unmute yourself.
Afternoon, team again.
Afternoon.
Thank you, Mr. Mashamo, for this wonderful presentation. You know, it reminds me back to class when I was just learning about substance use disorder, not opioids this time, but substance use disorder. So I've heard that there is a diagnostic criteria. They're using the DSM-5 TR, which is almost the same over the one we have been using maybe while I was in the college. For me, it sounds like I'm doing mental health today. So I've just left out there because of the network. How do you diagnose this client with the opioid use disorder? Yeah, I would think it's just because of the network there. I think I'm left out.
Thank you so much, Mr. Cyprian. We use the same criteria with the DSM-5, but the difference is that we need to also understand that tolerance and intolerance and withdrawal symptoms or dependency and withdrawal symptoms are not that much. We can look closer as the DSM-5, like others who are not prescribed. For example, these ones, you find that when they are in long term of the opioid, we are expecting them to become tolerant and have physical dependence on the drug because they have been there for a long time. That's one of the challenges of having a patient for a long time. But then, when we are looking for the others who have not been initiated to these drugs, then we will know that they will begin to have that dependence. Otherwise, for them who are taking opioids by prescription, we cannot then say if they are saying now it's like they are dependent on the drug, then we will say, if a patient comes to and say, I cannot sleep because I have not taken the drug, yet we know she cannot sleep because of pain, then we cannot say that now this patient is dependent on the drug. I don't know if I'm making sense. But then for this one, the classical part of it is, if the patient will continue to take this drug, even if the consequences, they are showing utility, then we can say now, this patient has indeed developed opioid use disorder. But then the DSM-5 will apply, but the critical or the classical one that would stay there, the loss of control will be very key for your diagnosis. I think I'm answering that. For this one is the use, even if the opioid is causing harm. Otherwise, on prescription, we expect the patient to continually take it and have the need to take it because it helps the patient to overcome the pain and improve quality of life. That's why you find that the issue of tolerance and withdrawal would be of ambiguity when it comes to this patient because they are on long-term opioid. They are already there. But once they begin to use them, despite the consequences that are negative, then we will say they have indeed developed OUDs. Thank you, Mr. Sikwe.
Okay, sorry, Mr. Mahlangu, thank you for the clarity. But I just want to know, because we are in the medical field, is tampering the same as weaning? So do I use the same procedure as I'm weaning a patient, maybe an epileptic patient now who's becoming better with the treatment? So now I'll just reduce the drugs steadily. That is weaning. I think is it the same? Because if I look at the procedure, it sounds the same.
It's the same. It's like you are going down the patient, you are reducing the effect. It's just that sometimes the patient will say, the dose you've prescribed me in the smart center is a little bit high. Can you kindly reduce? Then the principles of tapering or weaning, as I say, they will apply, then you will taper the patient down. Okay.
Thank you, Cyprian, for that question. I believe you are answered. I don't know if there's anyone else that wants to ask Mr. Mahlangu a question based on the presentation, colleagues. You can use the raise of hand or the chat box for a question or a comment. Okay. In the interest of time, can we kindly move to our case presentation for the day? We are supposed to be getting our case from the RFM palliative care team, but it seems like they haven't joined us.
Actually, the team, I've heard that the team from RFM, they've been summoned by their manager right now in another serious meeting, so they couldn't have time to come, so they apologize very well. Actually, I think they're still in the meeting and even now, so they apologize. What they say is that because that we continue, in our next session, they will come and respond to any questions. I think for us now is to learn and see what we can do in such a scenario like their case is. So maybe then in our next session, when they come back, we will then give them the opportunity to answer any questions we will have for them. Otherwise, now let's look at the patient. But for any recommendation, can be shared them with us so that we will then give them on what you suggested they can do to manage this patient. I think as the hub, we will read it for you, colleagues. So this is a 29-year-old male with chronic rectal cancer. The patient is having chronic severe pain on the lower back, and the complaint of severe pain on the lower back, pain score was out of 10. And this patient quality of pain is somatic and radiates with a score of 10. And the time they couldn't specify when it started, which is not specific, and it's categorized under chronic pain. So it's aggravating factors, there was none that was specified. And the patient has relieving factors that only include medication only. And the functional impact of the pain is that it reduces mobility, sitting, and sleep. And the current analgesia, they are more effective. For the current analgesia, the patient is using strong opioids. And the max effectiveness is 100% complete, which is more effective. And then for the physical assessment, the patient is in severe pain, cannot sit properly and relax on a chair because of pain, talks loud enough and clear, neat, and ambulates well, no pallor and dehydration. Where is it going? Ask his colleagues, I'm coming. I will be back very soon. Yes. I think now it will flow very well. So I was here. Psychological assessment showed that the patient is fully conscious, well-oriented, and time and place. There was no history of depression, anxiety, reported here. When you look at the social aspect, the patient is not working. Looking at this, they've just stated ambulatory instead of employment status. I don't know, maybe we'll ask them when they come back, but the patient is said to be self-employed, a carpenter, has done tertiary school, and is a middle-class person, is a single, a lifestyle. He has stopped taking alcohol and doesn't smoke, so there's a history of alcohol. The patient is from a family of 5 children. He stays alone at Fairview with mom at home, Louve, has a 15-month-old baby. He is a Christian and goes to Nazarene Church. He loves reading the Bible and praying. So significant medical history. The patient is a non-heart patient on treatment. He developed hemorrhoids 2019 and was done colostomy June 2021. And he also did biopsy June 2021 and results revealed that there was no malignancy. He was having specific wound in between buttocks that made doctors to prescribe antibiotics for him. He was enrolled on palliative care at RFM Hospital 16 September 2021. He was complaining of severe pain on lower, on lower abdomen and back. Pain score was 9 out of 10, brownish mucus discharge from rectum. He needed colostomy bags pain medication. He was using tramadol, parabotan, and diclofenac for pain relief. Tramadol was no longer effective in relieving his pain, and he was changed to morphine tablets since syrup was out of stock. He is still using morphine tablets, paracetamol, and bisacodyl for pain. He is currently refilling colostomy bags and pain medication at RFM. Previous medications are tramadol 50 milligrams, paracodyl 1 gram, bisacodyl 10 milligrams, and ciprofloxacin. And then currently is taking 30 milligrams of morphine, MST, BD, paracetamol 1 gram, POTDS, and bisacodyl 10 milligrams POD, and then his other regime has a T3CCBD and DGT OD. And then when we look at advanced care directives, there was none that has been done yet. However, he has suggested her mom to make decision for him in case he's unable to make a decision. And the mental capacity has been assessed, and the patient is mentally stable, and there are no any further concern under planning. When you look at the vital signs, the temperature is 36.1, and the BP was normal, and the pulse was 116, and respiration are normal, and SO2 also looks normal. The patient ECOG functionality status is ECOG 1, meaning is only reliant on medication. Otherwise, it's a functional person who's able to move around as long as he has taken his medications. And then when you look at the scoring of the symptoms, the abnormal symptoms that are here was pain, which was severe, and the anxiety that was also there. And then it was mild agitation, and sometimes, however, his poor mobility was also mild, was not that much effective. And then the patient was done Baralot and LTDL, and the results looked very good. And a plan of care based on the RFMT is that patient is currently refilling his medication and colostomy bags at RFM. He wishes to reverse the colostomy because getting the colostomy bag is now a problem, and his wound have healed, but still have severe pain. So RFM hospital will continue monitoring the client's wellness. I think that's what RFM has presented today about this patient. I don't know if anyone may want to add or ask anything about this patient from RFM, this male, a 29-year-old male. May I leave it to you, Tim? Anyone who has a comment concerning, yes, Cyprian? You can talk, Mr. Matsen.
Thank you again, Sandile. Is that patient a cancer patient, isn't it?
Yes, it's a chronic rectal ulcer. They are saying here only. They are not saying whether it's cancer or what.
It's what? Rectal ulcer, chronic rectal ulcer.
Yes.
Okay, thank you, sir. But I'm wondering if it's not cancer, this thing. Why didn't they take biopsy there to see if ever it's cancerous or not cancerous, the ulcer there?
They are saying
because it might leave.
In June 2021, they said that they did biopsy and it revealed that it was not malignant.
Oh, okay. Oh, all right. Thank you.
Yes. Yes, Nathaniel. I see your hand up.
No, I'm not saying anything. I'm sorry.
Anyone who may suggest anything or learn or because we might have patients like this in our facilities and we will have a challenge of managing. Otherwise, what I like about them is that they focus their treatment on the chronic pain and they are following up with this patient and he looks doing good. One thing I can say is that there's only one area I think we need to be very cautious of anytime we are prescribing weak opioids. There's an area where they say the patient was given tramadol and paracodeine, and it ended, the tramadol ended up not being effective in relieving the pain. Okay, the patient was using tramadol, paracodeine, and dicyclone. There's a danger in this combination of medication that we need to deal in case we meet patients like this one. The first thing that it is not recommended by WHO, CDC, or any pain specialist to combine the weak opioids or any opioids in one patient. For example, you cannot give tramadol and paracodeine in the same time. The reason is tramadol is metabolized by the liver to produce same effect as morphine. So it comes like that. I'll just make it that way for now. And then paracodeine, another codeine, has a little amount of codeine in it, which the body will metabolize into morphine again. So if they are giving these two different drugs, tramadol is under these opioids because it is another way of metabolism and it routes to the effects of control of opioid receptors. But the one that will reach the opioid receptor first, between these two opioids, will close the receptors. And the other opioid that you have prescribed together with this one will go to the addiction center. And it will push this person very fast to become an opioid use disorder, to develop opioid use disorder. So that, for that reason, then we end up saying patients are abusing drugs, patients have developed opioid use disorder. It's because we push them to develop opioid use disorder by prescribing double opioids that are not the same. For example, it is okay to give morphine tablets together with liquid morphine. That one is okay, because one will be the background dose, and then the other will work as a breakthrough dose. So it's not a problem that way. But you cannot prescribe a morphine and a tramadol or a paracotin, because one will reach the opioid receptor and manage the pain, and the other one will go straight to the addiction. So I think that's one of the issues we need to be very cautious of here. They are lucky if then the patient has not developed opioid use disorder, because that one will quickly move the patient there. That's what I can say with this issue of prescription of opioids. Another one is, what is good about this patient is, if you are prescribing opioids, you can prescribe non-opioids like they did with diclofenac today. That one is okay. But then when it comes to the prescription of morphine, then they are saying the patient is using morphine tablets, paracetamol, Pisacoldine. There is also another problem here that you need to look closer to. It is okay to prescribe these 3 tablets, morphine, paracetamol, Pisacoldine, but there's something missing with this medication. It is very weird. This patient has a history of developing PALS. I will say so. Then prescribing morphine and a stool pusher, which stimulates the Pisacoldine alone, predispose the patient to higher risk of developing other piles again, because he will be pushing these hard stools, so he will develop these piles. You will see most of the patients, you will find them ambulatory having piles after some time. If you trace their history, you will find them taking morphine together with Pisacoldine without a stool softener, which might be lactose or liquid paraffin. So it is recommended then, if you are prescribing an opioid, especially like morphine is, combine the laxatives, have a stool pusher or a stimulant plus a stool softener to prevent the patient to develop these piles in the future. Otherwise, another issue, I would say in this prescription, whenever you are prescribing long-acting opioids, like the tablets, the MST, 30 milligram BD, always prescribe a breakthrough dose that the patient will use. Normally, the breakthrough dose for morphine is the liquid morphine. Then the patient will have the tablet and the liquid. We know we are economizing, but sometimes they will frequently come to hospital because then at some point you will find that they could not sustain the pain until they take the dose after 12 hours. That's what I can say here. This then pushes us to the one next session that will come, whereby we'll look at the issues of breakthrough dose, incident dose, and dose failures. We'll be looking at neuropathic pain in the next coming sessions, which will be presented by our professors from Uganda. I will say then, let's not miss those sessions because they are very critical to help us as clinicians to deal with these gaps in management of pain, because if then we have these gaps, we continually expose our patients to more pain, and then they end up misusing the opioid. And then when they are misusing, we then tempt them opioid abusers. Yet it is not true if we are managing the pain very well in communication. And even if it's an opioid use disorder like this one, he has high risk of developing an opioid use disorder because he has been using alcohol in his history. So we need to screen this person now and then for any risk of opioid substance use disorder, so we can eliminate them as soon as they appear to help the patient, not at any point in time go there. Thank you so much. For my side is the one. I don't know if you have anything to participate to RFM team before maybe the evening, Messi. Please. I don't know if anyone wants to add, but otherwise, this is what I can share in this scenario.
Thank you, Mr. Mashamu, for going through the RFM case. I don't know if we have any questions or any recommendations. on how the client can be better managed by the RFM team. And as Mr. Mahlangu has said before, for any questions or recommendations, we will be able to share them with the team so that for our next session, we can actually start off with the case so that they can probably give us clarity on certain areas where there's concerns. So do we have any questions or comments or recommendations? Okay, whilst awaiting the response, colleagues, we can go to our chat box and actually click the feedback link so that we can give feedback for today's session. We are having our next session on the 27th of September, where we'll be looking at incident and end of dose failure, pain management in palliative care. So please invite other colleagues to join us for our next session on the 27th, where we'll be looking at incident and end of dose failure, pain management in palliative care. There aren't any comments or raised hands that I am seeing. So I believe that this marks the end of our session. So thank you for joining us, colleagues. We are hoping that next time we're going to have the RFM team start off with the case presentation just briefly before we get into our didactic session presentation and the case presentation for the 27th of September. So thank you for joining us, colleagues. Do have a lovely evening.
Thank you, guys. Have a nice day.